So my name is Michelle Plum. I'm one of the first-year pharmacy residents, and today I'm going to talk about trauma alerts. So this would affect pharmacy technicians in the ED, in the IV room, in the inpatient pharmacy, or really wherever you're working. So our objectives will be to recognize the different levels of trauma alerts, and so that would be alpha, beta, and gamma, and how employees are notified that a trauma patient is coming in. To identify who would be present in the room during a trauma patient alert and how each different role would be positioned around the patient. To select a pharmacologic agent that may be required for different complications of a trauma, such as RSI or massive trauma infusion, or the different medications that would be classified as emergent, urgent, or routine. So just before we start, some of the abbreviations I may use during the presentation, just so that you're familiar with them. So ED, as you know, is Emergency Department. EMS, Emergency Medical Service. SBP is the systolic blood pressure, or the top number on a blood pressure. GSW is gunshot wound. PRBCs, packed red blood cells, so this is what's given during a blood transfusion, and GCS is the Glasgow Coma Scale. This is a score that you'll hear when you hear that the patient is coming in. They'll usually say a GCS and a certain number. 15 is fully conscious, so like you and I are right now, and 3 would be no response at all, so the patient is completely comatose, but they are still alive. And so the numbers are based on their response to stimulation, so eye response, verbal response, and motor response. And then these 3 words I'll be using for each medication that we talk about throughout the presentation. So medications that are needed emergently would be needed within seconds to minutes, and any delay can actually really affect the patient outcomes. And so this would be the patient is in a life-threatening or unstable situation, and they need immediate intervention. Urgently needed medications are needed as quickly as possible, but this is more within a minute's range, and then maybe a minute delay wouldn't necessarily affect the patient in the long term as those emergent medications would possibly affect. And then routine medications. So if a patient is ordered a medication, it's important that they do get it, but this one, the timeliness of administration may not be as important to their overall outcome. So this would be like maybe a daily medication that they take on a chronic basis. So to start with the classifications of trauma alerts, so this would come through on the pharmacist will have a pager in the emergency department, and then there's also a TV screen up on the wall between the 2 trauma bays. And so the patient would either be classified as an alpha, beta, or gamma. Alpha is the most severe and emergent type of trauma, and this is patients who are requiring any type of airway stabilization, and then most likely require an intubation, so something good to know ahead of time if you hear an alpha alert to make sure the RSI medications are all refilled in the Pyxis, and we'll go over that on the following slides. Or if they're having low blood pressure, their GCS is less than 9, or if they had a gunshot wound or stab wound to more vital parts of the body. A beta alert is the one you'll see most often. So these patients could also require intubation, but they are already intubated out in the field with the emergency medical responders, but sometimes we may need to redo that in the hospital in a more clean area once they arrive to us. Their blood pressure could also be low, but not as unstably low as the alpha alerts. Their GCS can be less than 15, but if they're less than 9, they would be upgraded to an alpha alert. And then this would also include any skull fractures or neurologic problems, so any type of injury to the head. And then a gamma alert, and so this is the least severe injuries, but it still is a trauma alert. So the pharmacist in the emergency department isn't required to respond to this type of alert, but we usually are there just to offer our assistance if needed, and then if it is requested, then we would definitely jump in and help there as well. And so where to find the pharmacist during a trauma alert. So this is important for you because part of your main role would be to assist the pharmacist if needed. And so you can see here there's the patient bed in the doorway down at the bottom of the slide. And so at the foot of the bed there's the supply cart. And so this is where you'll most often find the pharmacist because they'll have space to draw up medications and all of the syringes and needles are kept there. But they really are moving around the room quite a bit, so they may be over near the head of the bed, handing a syringe to a nurse. They may be talking to the trauma chief about a medication that they think would be good to add to the plan. So you really just have to look around the room if you don't see them there at the supply cart. And then another important person to notice is the RN recorder that's also near the foot of the bed. So this is the person who will be recording any medications administered, anything that's going on during the alert. And so if you need the patient's name, if we do have that, a lot of times it's not available at this time. This is the person that you would ask, and they would give you the sticker with either the patient name and MRN or the anonymous name that was assigned to the patient when they came in if we don't know their name. And so your role in this situation is there's three main things that you can do to help. So being prepared. So we never know when a trauma alert would be coming in. It's usually something you find out, and it's an acute response, then everyone sets up and gets ready for them. So if we make sure the Pyxis machine has all of these key medications refilled on a regular basis, and if anything is getting low, that we have it replenished. This is really the best way that you can help to make sure these patients have the best outcome and receive the best treatment when they do arrive. Also supporting the pharmacist. So this may or may not be needed with every trauma alert, but we love to have you there to help us if we do need extra hands. So if there's a medication that's maybe not kept in the Pyxis, which would be rare because we try and keep the emergent medications right up in the ED, but if they're not there, you could definitely be a big help going down to the inpatient pharmacy and picking it from Talist, retrieving any medications from the tube station that are being sent up, so then we don't have to leave the room to go and get them, and then replacing any of the code trays, or you may know them as the pizza boxes, that are in the trauma room in case those are used and we need more medications. And then lastly, something that is extremely helpful but may or may not be possible for every trauma patient is medication reconciliation. So like I said earlier, we don't always know the patient's name, but if we do, it's really important that we find out which medications they were taking at home. So especially if they were taking an anticoagulant or antiplatelet medication, this could increase their risk of bleeding, and there are some medications that we can give to them to reverse the action of those medications. So if we do know their name, and if there's family around, you can look in their Epic chart, talk to the family, and then really the best way, if possible, is if their pharmacy is listed in their chart, to give them a call and try and get an accurate list of medications. And so you can let the pharmacist know whenever it seems like a good time to go in the room and let them know, but something that's important to let them know as soon as you find out is if they are taking one of those anticoagulant or antiplatelet medications, so that we can act quickly to reverse it. So these include things like warfarin, apixaban, rivaroxaban, dabigatran, Lovenox, and then the antiplatelets would be aspirin, clopidogrel, ticagrelor, or prasugrel. And if you ever have a question, if you're not sure if something would be dangerous to them or not, you can always feel free to ask. We would rather you ask and find out than to wait and then not be able to reverse something that would have been possible. So here we'll have a question. So question 1, an alpha level trauma alert is called due to an accidental gunshot wound. You're the emergency department pharmacy technician, and you're wondering how you could be of help. You ask the pharmacist if the patient has been identified, and they respond yes and hand you a name sticker. So what is something that you could do at this time? Could you look to see if there's a family member outside the room that could provide a medication history? B, look in their Epic chart to see if they have a pharmacy listed and then call that pharmacy. C, look in the patient's medication history on the home medication list in Epic, or D, all of the above. Yeah, so the correct answer would be D, all of the above. And you most likely wouldn't be able to do all of these, but if you can do any of the three, that's definitely more helpful than not. And then next, so this is the same patient. So we do have their name, and you find a pharmacy, and so you give that pharmacy a call, and they tell you the following 4 medications. And so which ones would you want to most urgently tell the pharmacist about? And the answer may be more than one. So clopidogrel, atorvastatin, metoprolol, or apixaban.
D and C.
So this answer would actually be A and D. So clopidogrel is an antiplatelet, and apixaban is an anticoagulant. So it's not as important that you know which type of which one is antiplatelet or anticoagulant, but just that those are two medications that can increase risk of bleeding. Knowing about C would also be important, just because that medication can slow down the heart rate, but they may not be needed that you tell us immediately like these other two, because these are something that we can reverse so that they don't bleed. So potential complications during trauma alert. So this is where you can come in, where medications are administered, and where we'll go over which medications are emergent, urgent, or routine. So this can include rapid sequence intubation, massive transfusion protocol, pain management, and sedation. So to start with rapid sequence intubation, you'll also hear it called RSI. So this is necessary when a patient is not able to effectively breathe on their own, and so then they can't have oxygen go into the blood and be delivered to all the tissues and organs in their body. So we have to take a tube, and they will put it in the patient's mouth and down their airway to restore adequate breathing. So to do this, the patient needs to be adequately sedated and then paralyzed for a short time to be able to get the tube through and down into the airway. So for sedation, our commonly used agents are etomidate, ketamine, and those are the two main ones. And then you may also see propofol or midazolam used in certain patient situations, but most likely you'll see etomidate or ketamine. And then for paralysis, the two that you'll see most commonly in RED are succinylcholine and rocuronium. And this one is largely succinylcholine, just because the rocuronium can last a lot longer, and then the patient would require even more sedation. So that's also something that you can keep in mind. And so all medications used for RSI would be considered emergent. So the longer we wait to get the proper medications in the room and delivered to the patient, the longer it would take to be able to intubate them. And so that's a longer time that they're not breathing efficiently to be able to deliver oxygen to their body. And so these are the medications, going through each of them individually. You'll see at the top the common concentration that we most often keep in the Pyxis in the ED at UVA. But in the light of multiple shortages lately, this is something that could change. As you see with the ketamine, normally we have 500 milligrams per 5 mLs, but because of the shortage, currently we have 200 milligrams per 20 ml. So it's just important to be familiar with shortages, so then when you're refilling the Pyxis, just to make sure what you're putting in there is actually what is up on the screen that says is contained in that QB, and then also that everything in there is all the same concentration, just so that there's no confusion or medication errors. So then there's also the typical number of vials that are used for an intubation on here, and this is important just so if you see that the Pyxis only has one vial left of etomidate, that most likely isn't enough to intubate even one patient. So that might be something you want to refill pretty quickly, especially if there's multiple patients coming in for any of these. So usually we use 2 vials of etomidate, 1 of ketamine or propofol, and the midazolam is very rarely used in this situation because we require so much, and then that would increase the patient's risk of low blood pressure. So then we would use 2 vials just because we need to give such a high dose. And then next is paralysis. So all those 4 sedation medications are all kept in the Pyxis and the QBs. And then the paralysis medications, succinylcholine and rocuronium, are also kept in the Pyxis, but they're in the refrigerator. We usually would use just 1 vial of succinylcholine or 2 of rocuronium. And neither of these are a controlled substance, just to be able to keep that in mind. And these are also emergent. So a question about RSI. So you're working at the UVA ED, and a patient with a beta trauma alert is coming in, and they require rapid intubation. There's a new nurse working. It's her first shift at UVA, and she asks you if you can go down to the pharmacy to get the RSI medications for her, etomidate and succinylcholine. So what should you do? A, explain how to get to the basement and then tell her to go down and ask for them at the pharmacy pickup window. B, state that you're unable to pull the medication because they're controlled substances and they wouldn't be remaining in your possession. C, tell her that these medications are actually kept in the Pyxis in the emergency department, and then show her where those are because it's her first day here. or D, agree to go down to get the medications from the pharmacy, but after you complete a medication reconciliation for a different patient. And so the answer to this one is C. So these medications are kept in the Pyxis, and so you can show her where that is. So because they're needed emergently, we hopefully wouldn't need to go downstairs to get them, and that's why we choose to store them there. And although D, it's very helpful to get medication reconciliations for other patients, we would want to make sure we're taking care of the most acute need first, and so the intubation would definitely take precedence over the medication reconciliation on the other patient. All right, so then the next possible complication that we need to address for trauma patients is they may require a massive transfusion protocol. So if a patient is bleeding excessively and requires greater than 10 units of packed red blood cells within 24 hours, this would classify them as a patient that we would follow the massive transfusion protocol for. And so when they receive that amount of blood, then there are medications that we also need to administer to prevent any complications from the amount of blood they've received. So these would include IV calcium chloride and IV sodium bicarbonate. And then also, not to combat the blood, but to prevent further bleeding, tranexamic acid can also be used in these patients. And this can also be used in a patient who is not in the massive transfusion protocol or receiving blood, but just a patient who has a risk of bleeding and we want to help their wound to clot off. And so these medications would be required urgently. So not within seconds, it's okay to have a minute or two delay, but we would definitely want it within less than 5 to 10 minutes. And so I think it's important to know why these medications are important. So then if you have the reason in your head of why they're needed, then you'll understand why it's so vital that we get them to the patient in a timely manner. So here on the left, you can see that this is the clotting cascade, so the way our body forms a clot to stop bleeding. And if you look in each step with these yellow circles, you'll see that ionized calcium is needed at almost every step of this cascade. And so when we give packed red blood cells to the patient, inside that bag there's also citrate. The citrate can bind to the ionized calcium that we have in the body, and then this isn't available to work in each step of this cascade, and the body is unable to clot. So when we give calcium chloride to the patient, we are replacing that ionized calcium store, and then they are able to continue down the clotting cascade, and the bleeding will stop. And so this yellow box is the same box you would see in our code carts, and this is what we would use in this situation as well, so the 10% calcium chloride. And this is stored in both the ED Pyxis and the code trays, so in those pizza boxes that are kept in both of the trauma bays. So if it ever runs out in the Pyxis machine, or if there's multiple patients coming in, maybe there was a large car accident and you run out in the Pyxis, there's always more in those code trays, and then down in the pharmacy if needed. And so the number used on each patient would be variable depending on how many units of blood they received, and then also what their current ionized calcium level is. And also something to keep in mind, if we ever did run out of calcium chloride or you couldn't find more, calcium gluconate is also appropriate to use. We just usually prefer calcium chloride because the amount of actual calcium contained in the same volume of the two, there's more calcium in calcium chloride, and so you would require a much larger volume of calcium gluconate to be administered to give the same amount. And then next is sodium bicarb. So this is also the same box that you would see in the code carts. And so this is kept in the Pyxis and the code carts as well. And the reason this is important is because our normal body pH, which is how acidic or basic our blood is about 7.35. And the lower the number is heading more toward an acidic state. So stored blood, as it sits around in the bags waiting to be administered to a patient, the pH actually drops. So it can be anywhere between 7 and as low as 6.6. So the more blood the patient gets, the lower their pH of the body becomes, and they're more acidotic, which can lead to a metabolic acidosis. And this is dangerous because it can lead to hypoperfusion, which is a decreased blood flow to the organs and tissues in the body, and then it can decrease the body's ability to clot and stop the bleeding. And so for this situation, we usually use the 8.4% of 1 MEq per ml, and this is a syringe that comes in the box. And this one is also variable, like the calcium, for how much blood they've received, and then what their pH is. And then lastly, tranexamic acid. So this can be given to a patient even if they're not receiving blood, but if they are bleeding. And the reason this is important to have available quickly is because in the studies when this drug was approved, or when this drug was looked at specifically in trauma, it had improved mortality when it was given within 3 hours of the injury, but then it actually had an increased risk of death if it was given greater than 3 hours after the injury. And so 3 hours sounds like a long time, but oftentimes by the time something happens to the patient, 911 is called and EMS arrives on the scene and gets the patient to the hospital. A lot of times we are quickly approaching that 3-hour mark, and we want to be able to get this to them quickly so that they can clot and stop bleeding at their wound. So this is given in 2 parts. There's the first dose that's given more rapidly, so one whole vial, so a gram is given, and this is made by the pharmacist at bedside. They can draw it up and put it into the saline bag, and that's given over 10 minutes. This isn't always done because sometimes this is done out in the field by EMS before the patient even arrives, and that's the one that we're looking to give more urgently. And then after that, once that finishes, we would give them another gram, but this would be infused over 8 hours. So this would come up from the IV room, and so this can be something that you can be looking out for if we let you know, hey, the patient received their first dose and we're just waiting for the infusion. You can grab that from the tube station whenever it comes through if you see it. And so this is needed urgently, so not within minutes, but just we want to try and get it in before that 3 hours. So once we find out we're going to administer it, we want to act quickly. And then lastly, just to include in the bleeding section, but not a part of the massive transfusion protocol, is possible administration of Kcentra. So this is prothrombin complex concentrate. We can just refer to it as 4-factor PCC. So this can be required in certain patients who we have a concern that they may be on an anticoagulant, specifically warfarin, and bleeding. And so this can reverse the action of warfarin, which blocks certain clotting factors. So if the patient has an intracranial hemorrhage or bleeding in the head and we know that they were taking warfarin, or if a patient had a blunt or penetrating trauma, and then they have an elevated INR, but we're not sure if they were taking warfarin, but we know they are taking some type of anticoagulant. These are 2 reasons why the trauma chief or emergency room physician would request that we give Kcentra. And as soon as you hear that we're going to be giving this medication, we want to act quickly. So this is given as soon as possible, but it does need to be mixed down in the IV room, and so that can take time. And then a big thing to know is it can't be tubed. So this is an important role for you. You can run down to the pharmacy and get it as soon as it's ready so that we can have it up to the patient as soon as possible. But the pharmacist can stay up in the ED at bedside in case other medications are needed in the meantime. And so the reason that this also has a little caveat to it when we're ordering it is because normally you have the dose of medication on the vial and that's actually what's in there. But if you look at these boxes, it says 1,000 unit range and 500 unit range. And this is because when the vials are made, they can't pick the exact amount of factor that is in the product. And so it's around that amount. So if you look on the left, this one it says factor 9. There's 569 units contained in that vial. And then the full vial is used to create the product. So when the order is entered, we want to make sure that however many units we're giving is a multiple of the actual units on the boxes that we have available in the IV room. So we usually would call down there to see what's available in the Pyxis and then make sure our order matches. And this is definitely something that you can be a big help with to get that number for us so then we can get that order placed more quickly. So for the end of massive transfusion protocol, we have a question. And so you're working in the UVA ED, and a massive transfusion protocol is initiated for 4 patients who came with EMS after a multi-vehicle accident. So the pharmacist is worried because the Pyxis is out of calcium chloride and sodium bicarb after only 2 patients. What can you do to help? So A, panic because this is an emergent medication and there won't be enough time to go downstairs to get additional supply from the inpatient pharmacy. B, check if the second ED Pyxis machine has an additional supply. C, go down to the inpatient pharmacy to get more when the situation has calmed down because this medication is not urgent. Or D, to inform the pharmacist that additional supply is available in the code tray, which may be a good option because this is an urgent medication. Or the last answer, E, is it B and D? Yes, that's correct. So B and D. So we can first check the Pyxis because there are 2 Pyxis machines on either side of the trauma bays, and then those code tray boxes, which are also in both trauma bay, will contain the medications. So pain and sedation. So even though pain may sound as though it's not as urgent because pain wouldn't necessarily kill the patient or make them unstable, it may seem, but it actually can contribute to their instability. So if uncontrolled pain can lead to an increased respiratory rate, increased heart rate, it can increase the patient's blood pressure, agitation, and so then it would be hard to control the patient's body movements, which may be important in certain situations to keep them still. So in many cases, rapid and adequate pain control in the patient in these situations is really vital to both the patient and staff safety. So for the most rapidly acting pain relief, the most common one that we use is a fentanyl bolus, which you see a picture here on the right. And then for most urgent sedation management, we can use a midazolam bolus, which is also on the right. Both of these are often continued as a drip, which would be in an IV bag or a large syringe based on the shortage situations. It may be supplied differently. And then so these can be used for continued control, but the most urgently needed would be at least just the vials, because if we need the drip, but maybe we have to wait a little longer, we can always continue to give bolus doses in the meantime while we wait for the continuous drip to start. And then so lastly, another medication we might need for a trauma patient is antibiotics. So depending on what happened to them, if they have any type of open wound that occurred from the trauma, that's a good place for bacteria to enter the body, and then this can lead to infection. So depending on what happened to this specific patient, if an antibiotic is needed, usually we would use what you see below, the cefazolin, clindamycin, penicillin, ampicillin, sulbactam or unicin, and gentamicin. And all of these are kept in the ED Pyxis except for gentamicin. So this would be coming up in the tube station, and you can always grab that and bring that in to get that started with the pharmacist. And so then your role also, besides the tube station, because the most of the medications are in the Pyxis, just making sure that there's always an adequate supply available so that when it is needed, we can get that on board for the patient quickly. And so our last question, so you're working as in the inpatient pharmacy and you receive stockout alerts in the ED Pyxis for the following medications: succinylcholine, amoxicillin clavulanate or augmentin, ketamine, tranexamic acid, and atorvastatin. So place these medications in order of urgency that are most important to refill from the most important to the least important to do first. So A, tranexamic acid, followed by ketamine and succinylcholine, augmentin, atorvastatin. B is succinylcholine and ketamine, tranexamic acid, augmentin, and atorvastatin. C, tranexamic acid, atorvastatin, succinylcholine, ketamine, and augmentin. Or is it D, succinylcholine and ketamine, followed by atorvastatin, augmentin, and tranexamic acid? Close. So your first choice was the first most urgent medication was correct. Succinylcholine and ketamine are both emergently needed medications because we use those to intubate a patient. But then we would have tranexamic acid next because this was the medication we wanted to give within 3 hours of the injury to prevent bleeding. So in D, atorvastatin is more of a routine medication that is important to give a patient, but it really isn't associated with any need to be timely or anything during an actual trauma. And then augmentin, this is important to give antibiotics timely, but in a trauma situation, they most likely would be receiving IV instead of oral antibiotics. So this one would be kind of lower on our list. And then lastly, atorvastatin as a routine medication. So just to review all the medications we went over. So the medications that would be needed most emergently are included here in the red box. So these are any medication for sedation and paralysis in RSI, as well as Kcentra. So I included this in emergent, which I defined earlier as within seconds to minutes. But because this needs to be mixed in the IV room, it would often take longer than that. But it's emergent because once we are able to get it and give it to the patient, we need to get it to them as soon as possible. And so the delay would be just because of the creating the product rather than actually trying to get it to the patient. And then urgent is here in our orange box, and so this would include the medications needed during massive transfusion protocol, and then also our pain and sedation medications if it's sedation outside of RSI, and IV antibiotics. And lastly, I just wanted to include this due to the current situations with drug shortages. This can really cause a lot of delay in our trauma response and complicate when we choose which medication to give based on what we have. So technicians can play a really key role in knowing what exactly we have in stock, what's in the Pyxis at that time, and so then if we are looking for a certain medication and that we can't find, rather than delaying, you would be able to tell us where this medication can be located or what we do have available at that time. All right, thank you for listening, and I will now take any questions. So I'm not sure if we have specific protocols in place, but the most key thing that the technicians can do in that case, if you are working in the emergency department and this does happen, is just making sure that you're continuously checking medication supply. And depending on how many people there are coming in, the inpatient pharmacy would definitely be notified of this, and we can we could even bring things up to you, and then if it's not a controlled medication, sometimes they may not even have time to be loaded into the Pyxis. We can just keep bringing it up and replenishing stock as needed to prevent any delay. But I can get back to you if there's any actual protocol that we have right now, but I know that we do have emergency procedures for mass casualty available that we can look at. So just because this is a human-derived product and not a medication that's just created in a lab, you're not able to actually determine by a certain weight how many units is in this and separate it out. And so they are able to instead, they know how many units they have, and if they put that in one vial, the reason we can't separate it is because say you have 630 units in a vial and it's in a total of 10 mLs. You can't assume that there's 63 units per ml because it doesn't evenly distribute throughout the whole liquid to make an even concentration. So if you take half of it, you may have a lot more units in half of that volume, and the other half may have only a fourth of the number of units. And so the way the product is made, you have to use the full vial to get that number of units, and you aren't able to separate it and actually be confident of what is in that volume. So most of the factor products, so there's other factor products other than Kcentra that are also used depending on what the patient is diagnosed with, a lot of hematology patients, and it's interesting, they're actually all dosed like this just because they're human products. So the EMS personnel would call in to the emergency room, and we have there's a main nurse who sits and triages patients, and so she'll get it's called a patch that comes in, and they'll tell her kind of what they know about the patient at the time. Sometimes it's not very much information, and then based on that, she'll talk to the ED physician, and they'll assign the level. And those levels are pretty spelled out in our trauma procedure packet for the ED. with those different criteria, and so then that is assigned and then sent out on the pager. But at any point, the trauma level can be upgraded. So if they're coming in and, which I've seen happen, they come in thinking, oh, this is a gamma trauma, and then the patient arrives and they're far more unstable than we had thought earlier, then it can be upgraded to an alpha trauma, and then the appropriate people from the trauma team would come. So there's always, if they're working up in the ED, it's good. They can always just stop by and say, hey, I'm here, let me know if you need anything, but they don't necessarily need to respond in the actual room. But for any of the alerts, usually the technician doesn't respond in the actual trauma room just because there's a large number of people in there. There can be upwards of 20 people in that room. And so usually they can just kind of hang by the door, let the pharmacist know that they're there, and then we would know to let them know if we need any help. But so then kind of a similar situation would be followed for the gamma trauma. So they can just make their presence known, but maybe not necessarily be in the room just because of how crowded it gets. All right. Thank you.